to introduce our speaker for this evening, who is, we're very pleased to have this opportunity to focus on really a different angle of the healthcare mix of things. And this is kind of a big picture, or you can kind of think about it as underpinnings that any healthcare bill that goes forward is that we want to be able to know what to look for, what's important, what's going to affect our economy in the long run. So we're very pleased that Jerome Dugan is with us. He's a professor. He's in the Department of Health and Systems and Science Research, and also the College of Nursing and Health Professions at Drexel University.
Yes.
And he's health management and policy, School of Public Health. You can see he has a wealth of active information, you know, that he can bring to this conversation and really talk about sort of the health of the marketplace. So with no further ado, I want to turn it over to Dr. Dugan, and we're going to mute, I think, just about everybody else here, okay? Jerome.
Yes.
There. Okay.
Yes, I'm here.
All right, so we're going to take about, you have about 15 to 20 minutes for your comments, then we'll take about 15 or so minutes of Q&A before we wrap up.
Okay, excellent. And I prepared a few notes in front of me to keep myself on task. Whenever I start talking about healthcare, it can sometimes last between a minute and a few days. So it's a quite complex subject. And today, I'm not going to focus so much on talking about specific healthcare bills, but rather what I want to talk about is some of the economic underpinnings of health insurance itself as a product. Also, I want to talk about some of the design challenges in developing a high-performance health insurance system. And additionally, I will touch on a few future directions. And within this talk, I'll talk about some of the old policies that have been implemented in order to bring about some efficiency to the healthcare system. I'll speak a little about the ACA and the attempts that the ACA has made in improving the healthcare system. And additionally, I'll talk a little bit about the Better Care Reconciliation Act, but very broadly, I'll be focusing on the major economic effects that each of these different pieces of legislation try to target. So the idea is to not really go into specific details about each piece of legislation, but rather to give you a clear theoretical understanding of insurance, and that will help you grade the quality of legislation moving forward. So it's literally changing, it seems, by the hour and by the day. And so it's very important to kind of keep perspective on the most important components of insurance. So health insurance, very broadly, if you ask an economist, will tell you that people buy insurance because they're risk averse. And this is quite true. Individuals face many risks when it comes related to health, and those risks that individuals face can include the health and life of an individual with illness and disease. Individuals face risk when they actually go about receiving treatment for a disease. And additionally, there are costs associated with receiving care and treatment for a specific disease. And again, there are costs associated with the regular maintenance of a disease if an individual is suffering from a chronic condition like cancer or heart failure. These are conditions that will lead to kind of continuous investments that have to be made. And in many cases, these investments are quite expensive. So ultimately, insurance is a mechanism that people use to assign risk away from themselves. So there are many risks that you can face health-wise. It's very difficult to try to manage with that on your own. So insurance is a product that is utilized to push risk away from yourself and into a third party, which we refer to as insurers. Now, people in general are going to transfer this risk to an insurer mostly by paying a certain amount. so a premium to an insurer, to ensure that they are able to kind of fully transfer that risk to that third party, that insurer. And ultimately, insurance firms will sell insurance products for a fee to assume the risk. And ultimately, what you'll end up seeing is that a marketplace will come about into existence where consumers are willing to pay for an insurance product for the price that an insurer sells. And the insurer is willing to accept that risk from a consumer in order to cover their payments and their healthcare needs, as long as they're willing to make those payments to them. And so when we think about the cost of insurance or the cost of this premium, this premium is largely going to be composed of two components. One is going to focus on the expected payout of medical claims. And additionally, as part of the insurance premium you pay, it's going to cover the administrative cost of a health insurer. It's going to cover the reserve funds that insurers are required to keep. It also covers the profit margin for the insurer. And so ultimately, what insurers will decide is to enter into a marketplace as long as they can induce the population to purchase the insurance for the costs that they charge. But most importantly, they'll enter markets where they can adequately assess the expected payouts. So ultimately, insurers are going to spend a lot of time to try to understand the quality of the patient population in order to kind of move forward. So insurers ultimately will enter markets where they can estimate the payouts to populations. And secondly, they'll enter marketplaces where they can assess adequately the degree of risk for them, which goes out again to the amount of cost that they'll actually face. So what I've described to you, a little bit of feedback. So what I described to you is kind of a simple insurance marketplace. You have insurers, they're willing to offer a product to consumers. If consumers purchase those products, they're able to distribute their risk. And insurers themselves, if they get enough consumers to actually purchase the insurance product, they're able to actually create an insurance marketplace. And that's largely the market that in the healthcare system that we actually are sitting in presently. However, before I go into talking about more kind of complex designs of health insurance, I first have to point out the problems with the simple insurance design that I described. And in describing the problems with the insurance design I described, I'll talk about how the US government and the private marketplace has gone about actually trying to resolve these issues. So the first major challenge that is faced in an insurance marketplace is that insurance is a product that is typically purchased. And therefore, we're making this very huge assumption that individuals can actually pay for and finance these products themselves. Now, this becomes something that's particularly problematic when we start looking at low-income populations and individuals, which oftentimes includes minority populations, which are disproportionately on the lower end of the income spectrum. And additionally, this is a significant challenge for individuals who are on a fixed income, who are nearing the kind of retirement age, maybe not necessarily quite age 65, where they can gain access to a Medicare product. So ultimately, cost is a very significant factor in being able to actually access insurance in order to actually push that risk of negative health effects away from the individual by paying that small premium fee. So the way that the marketplace typically handles the situation of individuals who can't quite afford to purchase insurance is to construct and create a publicly funded health insurance product. Now, this actually occurred back in the 1960s, where you saw the introduction of Medicaid, which is a program designed to target lower income populations, in particular, women with children, and also the Medicare program, which of course I think many people are aware of, which covers provides health insurance benefits to individuals typically age 65 and older. Additionally, over the years, especially during the Clinton administration, you saw an expansions to the health insurance program of Medicaid in particular, through the CHIP program, where you saw kind of an increasing number of individuals being added to Medicaid rolls, in particular children. Um, and so up until recently, up into 2010, that was the way that the marketplace and the government in particular tried to handle this issue of affordability of insurance plans. However, with the passage of the ACA, what you saw were a number of additional changes to the insurance marketplace to improve access through affordability of cost. First, there were expansions to Medicaid. So individuals making up to 138% of the poverty line can now access Medicaid. Most importantly, and very controversially, with Medicaid expansions under the Affordable Care Act, you saw that childless adults were now allowed to actually be on Medicaid as long as they were under that federal poverty line threshold. Additionally, the Affordable Care Act provided cost-sharing subsidies to insurers to help keep the cost of insurance products lower. And lastly, the Affordable Care Act provided tax credits to individuals in order to help them finance the purchase of health insurance from health insurance market exchanges. Now, very recently, what we've seen with a number of Republican proposals that have been put forward, in particular the Better Care Reconciliation Act, there were calls for an elimination of the Medicaid expansions. And this was largely due to the fact that there's this assumption that the Medicaid expansions under the Affordable Care Act were too robust. Individuals who had the capability of actually purchasing insurance were now being included on Medicaid rolls. And there was this argument for those individuals to be removed from those rolls. Additionally, there were calls to remove cost-sharing subsidies as part of the BCRA. And additionally, there was this proposal, especially I believe they refer to as the Cruz Amendment, to introduce lower quality, more affordable health insurance plans into the marketplace. And so the idea wasn't simply to kind of pull the rug under people, but in fact to try to provide a mechanism to increase affordability. And that mechanism for increasing affordability was to provide kind of these lower quality plans with less generous benefits back into the healthcare marketplace. So there's a second kind of major problem that's faced in health insurance marketplaces, and this involves this concept called moral hazard. And now with moral hazard, when people become insured, it is the case that sometimes individuals are affected by the coverage. So simply having the coverage itself affects individuals. And the effect that is problematic, at least from an economic perspective, is when individuals become more careless and they tend to overutilize health insurance services, which can be very problematic in the sense that if individuals are overutilizing services, this can lead to increased costs for the overall system, including insurance plans themselves, making them increasingly more unaffordable. In particular, moral hazard becomes a more serious problem when health insurers tend to cover a broader set of healthcare services, especially elective services. And so if there aren't any governors on how much care you can utilize, there are some individuals who would, if you allowed them, would walk into a hospital and get an MRI every single day. And that's a bit of an exaggeration, but without any type of mechanism to control use, that could introduce some major problems within the system. So um, the traditional way that we go about addressing this issue of moral hazard within insurance is to introduce deductibles, is to introduce co-payments or a co-insurance structure within health insurance plans. And so what deductibles do is it requires an individual to spend up to a particular threshold before benefits kick in. And with co-insurance, this is the kind of out-of-pocket expenses that you pay, the fractional percentage that you pay on the care that you use, is a mechanism primarily to ensure that individuals who exceed the deductible have a disincentive to overutilize care. So the idea is that if you have a stake in the cost of your use of care, that will, of course, reduce the inappropriate utilization of care. So under the most recent Republican proposals that have been put forward, there has been a call to reduce the level of benefits within health insurance plans as a way of actually curbing this issue of moral hazard. So the idea of getting rid of this essential benefits requirement within insurance, not comprehensively, but to allow plans within the marketplace that would discourage the overuse of care. Now, the Affordable Care Act, kind of backing up to that, really focused in on this idea of eliminating underwriting, so getting rid of these pre-existing condition clauses within insurance, and introducing these essential benefits, which are kind of a schedule of health services that every insurance plan is federally obligated to provide. And so under the ACA, I'd have to say it's not quite effective at getting at controlling this issue of moral hazard. But what it does do is attempts to address the issue of kind of a non-balancing of the insurance marketplace that I'll talk a little bit more in a second, by introducing an individual mandate to impose a certain amount of order within the healthcare system. Now, the last major challenge within any healthcare system, in particular any health insurance system, is this concept of adverse selection. So adverse selection is this economic concept where this condition exists when people with different health circumstances tend to increase the amount of insurance that they purchase. And theory suggests that people who know a lot about their insurance will be able to take advantage of insurers within a health insurance space because the insurers know much less information about them. And so because an individual knows much more about their individual health than an insurer, there's a certain amount of uncertainty and risk that insurers face when they offer a plan to an individual. There's a lack of understanding of whether or not that individual purposefully selected on that plan in order to utilize heavily those services. And this isn't problematic in itself outside of the fact that insurers tend to be more comfortable participating in marketplaces where they can anticipate what the utilization of the consumers will be. And if you have a lot of adverse selection present within the marketplace, there's a lot of misinformation about creating an expectation on how much care is ultimately going to be consumed by a consumer. And this is a particularly problematic economic effect that in the past was resolved by insurers structuring their benefits to avoid adverse selection. In particular, designing insurance products that covered very, very few services, or designing insurance products that kind of handpicked conditions that they wouldn't cover, like we won't cover cancer care, or we're not going to cover maternity benefits. And the idea was to kind of push certain populations away from the insurance products and to kind of get individuals who are less likely to incur those kind of high cost conditions into those insurance plans. A major problem with this is that if you create a marketplace where you have very cheap plans that are kind of take out conditions that healthy people tend to prefer, and you leave additional insurance options within the marketplace, which are more useful to an individual who is facing illness, then what you tend to see is that healthy individuals will tend to aggregate into these lower cost plans. And in these plans that have more comprehensive benefits, you tend to see sicker individuals aggregating towards those plans. And ultimately, you create the separating equilibria within the marketplace such that you have a population of insurance beneficiaries that are all sick. And of course, when you look at the average cost of all those individuals who are sick, it would require an insurance premium that is very high, and that's not sustainable at all for an insurer to support. So this can lead to the collapse of a health insurer within a marketplace. So the Affordable Care Act attempted to address this issue of the separation equilibria between healthy individuals and sicker individuals in insurance plans, but by requiring an individual mandate. And so what the individual mandate did was essentially said, everyone has to have insurance. And by introducing essential benefit requirement into federal plans, ultimately what happened was you saw this massive standardization in health insurance plans. And this largely mitigated the effects of adverse selection within marketplaces. And so there are a lot of positive design aspects of the ACA, especially the individual mandate and essential benefits with regard to kind of getting at this issue of adverse selection. Now, some of the more recent proposals that have been put forward by the Republican administration have been to get rid of essential benefits, to remove the individual mandate, and instead to create mechanisms that punish individuals who go without insurance or who select lower quality insurance plans who want to switch to a higher quality plan if they have a change in their health status, and also to provide funding to create high risk pools. So to directly address this kind of separation is for the government to step in and help pay to keep some of those costs down. Now, from an economic perspective, using an individual mandate and standardizing insurance plans is a good way of addressing this issue of adverse selection. On the other side, it is at least theoretically sound to address this issue of separation within a marketplace. If you allow for plans of different qualities within the marketplace, to simply provide additional funds for individuals to those insurers who are covering individuals who are disproportionately sick. And so from a theoretical perspective, these two different approaches can be quite effective at addressing those problems. However, in looking at the healthcare system as a whole, we don't see these problems in isolation. They actually all kind of interact together. This issue of cost, this issue of moral hazard being present within a marketplace, also this issue of adverse selection. And so, as many of you might have seen with the grading of some of these proposals that have been put forward, you've seen that a lot of the Republican plans have resulted in kind of very large swaths of the population going uninsured. There are a lot of comments within the CBO reports in particular that talk about increases in the prices of insurance premiums and cost, at least in the short run. But they also point out the fact that plans become cheaper over time. Now, the major challenge, though, with the a lot of the insurance plans that have been put forward recently is this issue of kind of a lack of equity within the healthcare system, where there are these concerns about whether or not it is okay to have millions of people uninsured within the healthcare system. So a lot of recent proposals that you've seen being put forward have been to kind of implement a Medicare-for-All type plan where you see a complete kind of migration away from private insurance and into kind of public insurance options. Additionally, you also see proposals being put forward to allow marketplaces in particular that have been struggling to attract insurers to allow individuals to actually enroll in Medicaid plans. And so an individual can actually buy into the Medicaid program and utilize that insurance benefit that already exists. So taking advantage of an institution structure that is already there and present. Lastly, major reforms that you'll see potentially moving forward are this issue of controlling prescription drug prices. So I largely talked about insurance with regard to it paying for treating illnesses and conditions. But it's important to remember that insurance also covers prescription drugs. And because of the structure of the prescription drug marketplace, they're allowed to introduce, control their charging. And so there have been proposals to allow a lot more flexibility and control to Congress to allow them to let people purchase drugs overseas, or to implement policies to require pharmaceuticals to charge what they refer to as fair prices for pharmaceuticals. Although I think it's a little difficult to define what fair is. So it'll be interesting to see what legislation like that might look like. So those are largely all the remarks that I wanted to make about health insurance. As I mentioned, and so if anyone has any questions or would like a clarification, please ask. I tried to follow a script as I mentioned beforehand. Sometimes I can go way off on tangents with talking about healthcare. But I guess this is a good opportunity to go off on a tangent or to address a follow-up question or maybe any other questions you might have about the current healthcare space. I'll answer it to the best of my ability.
Thank you, Jerome. Appreciate that very much. What I'm going to do is unmute all and at this time so that you can ask question, or if there's somebody right off the bat that wants to just raise their hand so I know. Let's see here. We had a number of people join us also later. I'm sorry, who was that? I thought I heard somebody speak.
Right.
Okay.
Well, yeah, I was just saying, I have a question.
Yes.
Oh, I do want to mention one thing now that we're moving into Q&A. We are recording this session. So just wanted to let you know in terms of before you start making your comments.
Wonderful.
Okay? Go ahead.
Okay. Question. I noticed that there was an awful lot of talk about this profit motive and how might we rid ourselves of that whole profit motive in healthcare. And secondly, how would a single payer system be an improvement on the current situation?
Both of those are really important questions. And I'll talk about the first issue of profit motive. So even within the healthcare space, you have for-profit and not-for-profit companies. And despite this for-profit or non-for-profit status, these institutions are interested in generating profits that they can use in order to enrich shareholders, because it is a business, or to create reserve funds that they can utilize to increase their investments within communities. And so when we talk about profit within the healthcare system, it's kind of a very kind of sticky topic because it's not always quite clear what the equity in profiting from someone's bad health or good health actually is. Within the Affordable Care Act, there are a number of different mechanisms in place to ensure that insurers are forced to do reinvestments back into consumers if they haven't spent those premiums on health-related items. So like a fraction of the premium has to go to health-related issues. And that's something within the ACA that has been put in place. However, within some of the Republican proposals, at least most that I've looked at, there isn't really too much proposals, components within the proposal I've seen that really have gotten at reducing this profit motive for health insurers within the system. Now, getting into this issue of a single payer system, I think it's important to note the fact that universal health care is not the same as a single payer system. A single payer system can bring about a universal healthcare system where every individual is covered. Additionally, there are ways of having private insurers within a marketplace and actually accomplishing universal coverage as well. And you see this in places like Germany, Italy, and Japan, where largely there is this kind of big presence of private insurers within the marketplace, and yet they're able to meet the needs of the entire population. Now, with the single payer health insurance system, much like the plan that Bernie Sanders has been promoting for a number of months, and also has, I guess, announced that he'll be kind of doing a tour around the United States to kind of pop up support on a single payer healthcare system. In large part is to introduce a public option within the healthcare space where anyone can purchase it and anyone can benefit from the coverage of the system. It's within the US context a little difficult to know whether or not the plan is to provide a federal public option plan that people can elect into. And so individuals will vote with their feet on whether or not they want to stay with the private insurance system or move to a public insurance system. Or alternatively, it's the case in implementing a single payer insurance system that would completely eliminate the private insurance system and require individuals, everyone, to enroll in Medicare and simply finance Medicare-for-All using tax dollars. And so right now, in the proposals for single payer systems, at least at the federal level, it's a little unclear on how they would want to go about the financing of the insurance itself and whether or not they want to leave a public option available within the insurance space for people to choose whether they want to participate in it or not. Did that answer your question, John?
No.
Yes, it did pretty much for me. I just I just want to see something done.
Yeah, I think we've kind of reached the point. Oh, could you repeat that?
No, I'm just anxious to see something where we no longer have people sitting out here who cannot afford any kind of care. And if you have a pre-existing condition, oh, sorry, too bad.
Yeah.
I just want to see that everybody is covered.
Yeah, there are a number of different strategies to go about covering everyone, but I suspect that probably the most popular approach will be in the coming months is this idea of Medicare-for-All and basically slowly migrating the US system into a single payer system. It's really important to note that if our country decides to migrate to a single payer system, this isn't something that's going to happen overnight. This is something that's going to go, years and years and years, where individuals are slowly funneled into the system, and Congress makes a decision on how to handle the private health insurance industry and how they'd actually participate in the new insurance marketplace. When it comes to Medicaid programs run by the state, many states like Florida and Louisiana actually have private insurers running the Medicaid program, handling the logistics and claims, through managed care plans within those states. So so there's definitely a role, even if you in the United States move towards a single payer system, for private insurers to participate. So again, like I said, it'll be really interesting to see what lawmakers, at least on the Democratic side, to start to coalesce around. I would suspect that in the event that a single payer system becomes a viable option politically to push forward and implement, you might see on this conservative side a push to allow individuals to pay for to access state Medicaid systems. So at the very least, to keep control of public insurance options within states and not allow a complete federal takeover. But that's just really speculative from the reading I've done up to this point. But it's something worth paying attention to if you start hearing people talk about, oh, state rights, you know, we've accepted that there's going to be a public option, but we want to control it. And we don't want the federal government to decide, you know, the type of insurance that you have. So that's something definitely to keep an eye on.
Okay, let's take a couple of more questions. Let's see, did it see Michael? Do you want to unmute yourself? Can you unmute yourself there, or I can unmute?
All right.
Got you? Okay.
Yep. Can you hear me? Well, thank you, Professor Dugan, for coming tonight. It's very interesting. You mentioned moral hazard, and I've seen some data, but not a lot, from some of the European systems where, you know, when you have lower deductibles, or for lower income groups, hardly any deductibles, there's not necessarily an enormous increase in the use of the services, because frankly, the experience of using a doctor is sometimes not that all enjoyable. So I wonder if the moral hazard argument is really valuable. I mean, if people will there'll be a massive abuse, let's say, of the system because people don't pay. I don't know if there's really a lot of data on that, because my experience and the little data I've seen doesn't really show that there's a big issue for healthcare when you don't have those copays, that people actually use the services more. There are some exceptions, of course, but I don't know if you've seen any data that backs up that theory about moral hazard and healthcare for especially deductibles.
Okay, and I'll try to keep my response a little shorter this time.
Yeah.
Like I said, I can be a little long-winded. But with regard to this issue of moral hazard and individuals who don't face the full consequences of their action, that is utilization of care, would potentially overutilize or abuse that service. There is quite a bit of evidence that suggests that the use of deductibles and co-payments can in fact alter the consumption of various different medical services. And so this, as I mentioned, it's a lot of the economic evidence, at least in studies I've reviewed, have observed moral hazard within the health system. It isn't necessarily something so extreme that individuals are getting MRIs every day if they aren't facing the full cost. You don't see that within the Medicaid system, for example, where deductibles are basically non-existent and co-payments are very low. People aren't just overutilizing MRIs. But in the research that I examine, what you tend to see is that individuals will utilize, especially within the Medicaid program, types of care that tend to be more expensive. So instead of scheduling routine services, you tend to see them going to the emergency room, which is by far one of the most expensive places for you to utilize care. Now, in many cases, you can use moral hazard as a tool. In the case of the Affordable Care Act, the healthcare law made getting annuals free, essentially for every insurance plan. And the idea was, well, you know, we really want people to get routine health services, to get routine screenings, because ultimately, if you're getting routine care, you're getting more physician advice, you're able to detect diseases much sooner, and ultimately over the entire life cycle of an individual, this will lead to lower overall cost. In particular, when individuals go into the Medicare program, they're much healthier going into that program, which can create cost savings for individuals kind of nearing their more senior years. And so moral hazard, at least within the US case, a lot of studies don't point to it being as a deal breaker to kind of implementing a system where you have universal access given to individuals. But definitely asking an individual to pay a co-payment, even if it's a small one, can disincentivize someone from maybe on the margin utilizing a health service that they don't need to, especially when it comes to elective services.
Okay. Thank you.
Any other questions? I think we can take about one more. We have about 4 of our advocacy core, UUSJ's Capitol Hill Advocacy Corps people on here. Martha and Bob McCarthy, in addition to Pat, who I mentioned earlier, and John Gubbins comes. When you go to some of those offices, are there some questions related to this that you're thinking about that you might want to ask Dr. Dugan? Especially for our, as we go to the Hill, for talking with and for folks who are contacting their, during the recess, hopefully folks are going to have opportunity to continue to raise these issues in the town hall meetings or in district. Any thoughts about that? Or questions? Okay, Kendra, hi. Unmute you here. There you go.
Is there a case for saying that introducing Medicare for all would be a lower cost overall over time that might help persuade conservatives towards that program? Can we use a financial incentive to persuade conservatives?
Yeah, absolutely. The most recent article I read on what the potential cost of Medicare for all would be, someone said transitioning to that new system would cost something on the order of maybe $32 billion. And I know that Bernie Sanders came out and made some comments about the fact that some of those figures are completely inaccurate. It definitely is the case from a theoretical perspective that by introducing a single payer system, you move to one logistical system. And you can take advantage of those economies of scale where you have so many individuals who are using the same insurance plan with standardized reimbursement, standardized negotiation with basically every medical institution, because you could federally require that would in fact generate a pretty significant cost savings. On top of that, if you introduce evidence-based decision-making within care, focusing on covering services which have been found to be cost-effective to improve quality of life and to extend life versus other services that maybe aren't necessarily that effective from a cost perspective with extending life or improving quality of life, then I think it's in fact the case that a single payer system can perform quite competitively to a public insurance system. A lot of people are going to use the National Health Service overseas in Great Britain as an example for why we shouldn't move to a single payer system. But I would make the argument that if you look at the average cost of healthcare per individual across kind of the spectrum of kind of highly developed economies, you find that the United States spends such a significant amount of money per head on healthcare that pretty much any other system is going to be more cost effective. I mean, almost anything would be more cost effective than the system we have now. So I think it's kind of a stretch to suggest that Medicare for all would be a worse off system for the United States from a cost perspective. Maybe there's some other dimensions that people could point out, but definitely not cost.
Well, thank you. Well,
Thank you.
We're going to kind of wrap up here at this point. Thank you, Dr. Dugan. And I want to remind people again, we are recording this session. We will make it available for you in a couple of days. And Dr. Dugan, you have a site that maybe you can mention to us that you have information and you post information. Maybe folks might be interested.
Yeah, so I have Twitter, Professor Dugan, and occasionally I will tweet out articles about the healthcare system. So kind of a curated list if anyone's interested. Also, I have a website that my collaborator and I, Dr. Leila Bushiri, run. It's called the Health Economics Analytics Laboratory, and the website name is healresearch.org. And it just kind of describes our main mission, which is to use the latest computational techniques to examine policy failures in the healthcare system and also the welfare system as well. So it's very difficult to talk about healthcare without thinking about other social safety net programs within the United States. So recently, my collaborator and I won a NIH grant to examine financial decision-making following the passage of the ACA and looking at the impact of negative income transfers generated by the ACA on individuals and how they approach handling their care needs. And also, we're presently working on a project looking at peer mental health intervention into low-income populations, in particular single mothers and children, and what the economic impact of kind of group therapy is on making those groups more resilient. And so there's not so much specific content on the web page, but it definitely you can keep track of the activities of our laboratory, and definitely, and this is to anyone within the group, feel free to reach out to me via email or Twitter. If you have questions. I definitely spend way too much time on social media, so I might as well put some good use to it.
Well, thank you. Well, when we send out the link to the recording, we'll get that information from you. So that would be the Twitter, the website, and your email address. That would be helpful. Thank you.
Absolutely.
Great. So at this point, I would like to turn over for some comments to our partner, Michael Teasdale, who is the co-chair of the Unitarian Universalists for Just Economic Community. Earlier on, I had mentioned UUJEC and the UUs for Social Justice had co-hosted a conference here in DC. And again, this is a continuation of those programs. So Michael, want to wrap up? And
Sure. Thank you, Lavona. And thank everybody for coming, and especially yourself, Professor Dugan. I think it was very interesting and unique to get that sort of economic overview and perspective on healthcare. That's very helpful. And to everyone else, you know, as Lavona said, we've done the conference, but we're going to continue doing these webinars, you know, as a joint project for us, so we can bring people information to help them become more active and engaged in social justice. You know, the healthcare struggle is not done. I think Professor Dugan mentioned that there are some new bills being introduced, whether it's for single payer, whether it's to modify the present ACA. I think we need to stay abreast of that and make sure that, you know, our values are reflected in those bills. And I think that we hope with these webinars to continue to inform people for healthcare, but also for other issues. There are tax reform coming up. There's the budget coming up, all that can have a big effect on, you know, the welfare of people in the United States. And in fact, you know, as someone said, the budget is a reflection of our values. And we want to make sure that, you know, the budget that the U.S. government passes is influenced by the UU values. So we urge everyone, we'll probably be doing another one in a month. I think our goal has been to do one each month here. So we will be sending out emails to that effect to keep people aware. And I hope folks will come back. And again, last thanks to Professor Dugan. That was very interesting. And thank you for your, I don't know if you can clap online. Huh?
It was an absolute pleasure to speak to you all. Thank you for hosting me.
Okay, thank you.
Thank you. Bye.
Have a good evening, everybody.
Thank you very much. Bye-bye, everyone.
Bye.